And do we have a go in the back? So on behalf of the League of the Women Voters of Milwaukee County, I want to welcome you and thank you for being here. The League of Women Voters was founded in 1920, the year the 19th Amendment was adopted to ensure women's voting rights. We are a nonpartisan, nonprofit, grassroots organization with a mission to empower voters and defend democracy. From its inception, the League was about more than voting. It encouraged citizens to engage with elected officials and advocate for better government. As a nonpartisan organization, the League does not endorse or oppose political parties or candidates, but we do advocate for government policies that serve the public interest. The League of Women Voters of the U.S. adopted a public policy position on reproductive choice in 1983, saying that in a pluralistic society, we must affirm the constitutional right of privacy of the individual to make reproductive choices. In subsequent years, the League joined amicus briefs in a number of lawsuits challenging restrictions on access to abortion. In 1990, the League joined the National Pro-Choice Coalition and has continued to lobby for laws to protect access to reproductive health care. We are pleased to present tonight's forum to discuss the dire consequences of restrictions to abortion care. We believe an informed voter is a powerful voter. We urge you to share the information presented tonight and direct friends to the recording of this event, which we will be posted on the League of Women Voters Milwaukee County website. You know, I forgot to introduce myself. I'm Charlie Gabler, tonight's moderator. Our forum will explore the consequences of abortion restrictions, the ripple effect they have throughout all of reproductive health care, the closing of family planning clinics, increases in pregnancy complications, and maternal mortality post their passage. Unlike other developed countries who have experienced decrease in their maternal, can I continue? In their maternal mortality rates since 2000, our maternal mortality rates have increased, experiencing a rapid increase after 2019. Our rate is now 5 to 6 times higher than the other developed countries. Black women have maternal mortality rates 3 to 2 times that of white women. Tonight, we are fortunate to have a panel of passionate women's health advocates, Dr. Kathy Harke, DalveryBlackwell, and Representative Robyn Vining, who will review the Wisconsin impacts, the circumstances that drives our maternal mortality rates, why women of color, especially black women, are disproportionately impacted, and what can be done in Wisconsin to reduce these trends. Before we start, I have a couple of housekeeping details. All of you will see that there are pens and index cards on your chairs. If any presentation prompts you to have a question, please write it down, and the members of my committee will pick them up, post immediately after Dr. Hartke's and DalveryBlackwell's presentations. We will address 1 to 2 questions as time allows. We will also address questions after Representative Vining's presentation, and then after her 1 to 2 questions, all 3 of them will return to the stage, and we will have a general question and answer time from questions written on the card. The presentation may take around 75 minutes. So for those of you who's not familiar with No Studios, the restrooms are out the door and to the back. If you would like to have a beverage because you're thirsty during the presentation, please go back to the bar, but be respectful and quiet while you do that for the presenters. We know abortion care is a very personal decision and can provoke strong emotions. Please be respectful to all opinions expressed tonight. Now, here, Cheri Taylor had expected to be here in person to discuss her story. You know, giving women a voice in democracy and public policy is at the core of the League of Women Voters. And it only seemed fitting to start tonight's forum by giving a voice to a woman who had experienced a complex pregnancy loss that highlights the nuances and the near-death experiences women and their families face when limits on abortion care are in place. Cheri currently serves as the Philanthropy Officer for Principal and Major Gifts at Planned Parenthood of Wisconsin in the Madison office. Cheri is a Milwaukee native and earned her undergraduate degree from Harke University in Social Welfare and Justice and Women's Studies. Prior to joining Planned Parenthood of Wisconsin's development team, Cheri worked at the First Unitarian Society of Milwaukee in a number of capacities. Cheri currently lives in the Wisconsin Dells with her husband, Anthony, her 3 children, Maddie, who's 1, James, who is 3, and Anthony, who is 11, and their mini poodle. Cheri, we will hear her story from her video, but she would like to remind us she is not here today as a staff member of Planned Parenthood of Wisconsin, but as a Black Milwaukee native who has been personally impacted by the 2020 Dobbs decision. You know, I would like to thank Cheri for her courage and willingness to share her story. Unfortunately, in the transfer of technology, the end of it was, we have about 2/3 of it, so I will complete her story after her video is completed. Do I have to?
Hi, my name is Cheri Taylor, and I am honored to speak with you today as a Black Wisconsinite who has been personally impacted by the recent attacks on reproductive rights in the U.S. and in Wisconsin. I am so sorry that I wasn't able to make it to be with you all in person today, unfortunately, due to some unforeseen circumstances, but I am still glad to share my words with you. I remember when I first learned of the ruling of the Supreme Court decision regarding the Dobbs case back in 2022. I was actually in a meeting with a donor who was energized about mid-year elections while I was working for the Unitarian Universalist Association. It was when my 15-year-old daughter called me while at summer school in Madison with panic in her voice. I realized at that very moment that she will now live in a world that I never had to live in. Life without the right to bodily autonomy and the right to make the reproductive health care decisions that are centered on her wants and needs. In February of 2024, I learned that I was pregnant. And my experiences as a Black woman pregnant in Wisconsin post-Dobbs was one that I could have never imagined, especially with living in now a rural area. Facing the tough decision on what to do and being caught in the political warfare of how to safely terminate my pregnancy which was the decision that was best for me and my family. And it deepened the trauma that I had experienced with my last two pregnancies as a Black woman giving birth and finding myself in scenarios where my experiences and feelings were invalidated by those I had trusted in making health care decisions. Unfortunately, I suffered a missed miscarriage. And due to the complicated 1849 rule that was being used to outlaw abortion in Wisconsin, my body became part of the political warfare against abortion and on the rights of battleground. And this landed me in two hospitals with near fatal hemorrhaging. While in the hospital, I remember hearing the conversations amongst the medical staffs about no hopes of saving the fetus, which honestly was never my intention. And me being a mother of three children who were already on this earth.
Oops, yeah. Uh, oh, not not a woman who has agency in her life and healthcare decisions. It was very difficult. It caused me to cry and became angry during my recovery as I reflected on her experience. This is not something I want for my daughter or any person to have to deal with. As people, we have the right to make decisions that are best for us in consultation with those we trust who can provide comprehensive care and expert advice. I hope that my story can provide you some insight as you talk with your circle of family and friends as we approach this fall and spring elections in Wisconsin. It is not just abortion on the ballot. But equitable health care, reproductive health care that is accessible to all regardless of race, gender, and I can't see that, and location. And she thanks you. So those are, I wish she could have been here to share her powerful story. And unfortunately, there are many stories like that in Wisconsin. Our first speaker tonight is Dr. Kathy Harke, who is an accomplished obstetrician, gynecologist, and abortion provider. She graduated in 1983 from the Medical College of Wisconsin, completed her OB-GYN residency at Mount Sinai Medical Center in Milwaukee. After completing her residency, she made Milwaukee area her home, joining a private practice and becoming chair of the Department of Women's and Children's Services at Waukesha Memorial. During her time in practice, she became a women's health advocate, testing as an expert witness at the county and federal level on behalf of patients jailed by the Wisconsin Cocaine Mom Law. She worked with ACOG, the AMA, Wisconsin Medical Society, and the National Advocates for Pregnant Women. Their efforts resulted in the bill being found unconstitutional. Since that time, she has been actively engaged at the state level and is regularly consulted by state legislatures on women's health policies and asked to testify in support of women's health bills. She is the past chair of the Wisconsin section of the American College of Obstetricians and Gynecologists and served as the legislative chair for the Wisconsin ACOG. After retiring from clinical practice in 2018, she served for 5 years as the co-chair of the Wisconsin Maternal Mortality Review Team at the Department of Health Services. She currently continues her reproductive justice work by serving on the United Methodist Church and Society Committee on Women's Health and Reproductive Justice in Washington, D.C., and as the Wisconsin Social Action Chair for the United Women in Faith. Please join me in welcoming Dr. Hartke. There you go.
Well, we're getting set up here. Thank you, Charlie, and the Reproductive Rights Committee of the Milwaukee League of Women Voters. And thank you, League, for all the things that you do to help us be more informed and to help our society be better in so many different ways. And thank you for Cheri sharing her personal story. Those are difficult things for people to share, and I know we have some other people here who have done a lot of great work in sharing their stories so people understand what's really happening to individual lives. So there are, yes, very dire consequences to the impact of abortion restrictions in Wisconsin. And just to take us back a little bit, a lot of you might not even remember these times, but I see some young faces here. I started college in 1972 before we had rights to our body. And I know one person here that actually went to Mexico to have an abortion during that time period, which was a very scary thing and had complications and bleeding on return. So this was a terrible time. My mentors, when I started residency, told me about these septic abortion wards. There were, in every major city in the country, there were hospitals that had abortion wards where women were dying of sepsis, of severe infection because of trying to do self-induced abortions. Cook County had a 40-bed ward in Chicago. And at that time, that picture of is women who called themselves the Janes. This was in 1972, also known as the Service. And these very brave women defied the law and provided 11,000 safe abortions to women in Chicago. Let's not go back there. And there's a very real risk of that. I want to just show you the trailer of the HBO movie that you should probably try and find and
We
watch.
were ordinary women trying to save women's lives.
But we were criminals. We were felons. For most of the nation, in '72, abortion was illegal.
We had to go underground.
The woman would be given the address to the front.
It was probably obvious to neighbors what was going on.
We came to the surface from other things, the anti-war movement, the civil rights movement.
You couldn't not pay attention to what was going on.
Fetal death is murder.
You could not work as a pregnant woman. If you weren't married, you were out of luck.
They were
terrible situations.
The septic abortion ward was full every day.
Women did awful things.
They were literally dying because they were women.
So we thought we can be of use. I said, we could use my phone, but change it so that they don't ask for Eleanor. How about Jane? Nobody's called Jane anymore.
We had the phone numbers on bulletin boards around Chicago. Pregnant, call Jane.
The clientele included daughters, wives, mistresses of police, state's attorney, judges.
It dawned on me how big an issue this was.
Jane was an outrageous undertaking by a lot of smart women.
I was not there to pass judgment.
I knew there were women like me.
Under the radar of the Chicago Mafia and police department.
We were all being watched.
The phone rings. A man says, we know where you are.
There were 11 counts of conspiracy to commit abortion, 110 years for each of us. So that's a long time.
That might have ended Jane right then and there.
I couldn't see myself sitting on the sidelines.
We were building a new world, one woman at a time.
Sometimes you have to stand up to illegitimate authority. And sometimes there are unjust laws that need to be challenged.
Sometimes there are legitimate laws that need to be challenged, and we have to be on watch right now, very much so. So in January of '73, the Supreme Court issued the 7-2 decision on Jane Roe that gave women in the United States a fundamental right to choose whether to have an abortion without excessive government restriction, striking down the Texas abortion ban. And then, as you know, in 2022, June 24th, on a Friday, the Supreme Court changed all that, and the Constitution does not confer a right to abortion, overruled the authority of Roe and Casey, and gave the authority to regulate abortion returned to the people and their elected representatives, in other words, in the states. Wisconsin abortion stopped. Anything that was scheduled the next day at Planned Parenthood stopped. I got calls that day. I got a message from a doctor that I worked with for many years saying, I'm on call this weekend, what are we supposed to do? And we had already met with the Legislative Council for the American College of OBGYN in Wisconsin, talking about, what different hospitals were doing with their legal counsel. And nobody could agree on what was going to happen, but the fact was there was going to be this interpretation of the law that said we could not do abortions. And she said, what do I do if a woman comes in at 18 weeks pregnant and she's got ruptured membranes and the umbilical cord is in the vagina, and what are we supposed to do? And I said, I don't know, I can't tell you what to do, but I would, one, call your board, your hospital board, and two, do what you were trained to do. And if it were me, I would do what I knew how to do to do the right thing for that woman. If it meant going to jail, I would have done it, because we are not going to let women die on our watch. At least I'm not. And the only woman that I lost during my whole career was during residency, and she choked on a something and could not be brought to the hospital in time, and we did a post-mortem cesarean section but did not save the baby. So there are terrible binds that people were put into. There was significant provider distress. You could either do a felony and get up to 6 years in prison, loss of license, and $10,000 fine. Every time we get a law like this passed in Wisconsin, there's a huge fine and prison attached to it, or commit malpractice and potential death of a woman. And my colleague on the left was serving Planned Parenthood at the Sheboygan Clinic and was in the lawsuit, was named in the lawsuit against Planned Parenthood for doing abortions by the district attorney there, and then was also referred to the medical examining board to hopefully take away her license. She then moved to Minnesota and is now working 15 days a month in Minnesota because she does not want to work here right now until things get straightened out. But, I mean, this is what happens. We drive people away. The person on the right, Sarah Thompson, is an OBGYN in Idaho. Idaho has it much worse. And those people have a much stricter law, and they are actually airlifting women who need to have treatment to other states like Washington, Oregon, and Utah, because they know that the worst thing that they could do is, never recover from losing a mother that they know could be saved. And so we're put in this horrible bind. Since Roe was overturned, there's been a number of studies of moral distress of doctors across the country. In one, 96% of providers who care for pregnant women in states with restrictive laws reported feelings of moral distress ranging from uncomfortable to intense to worst possible. In a survey of OBGYNs who mostly were not abortion providers, more than 90% said the laws had prevented them or their colleagues from providing standard medical care. They described feeling muzzled, handcuffed, and straitjacketed. In another study, OBGYN residents reported feeling like puppets, a hypocrite, or a robot of the state under the abortion bans. I look at what happened in China where there were forced abortions. If we let the government tell us what to do with our bodies, it could go either way. So, it's not just that you can't get an abortion. At some point, you might be forced to have an abortion. Abortion is health care, and it's a woman's right. And the 1849 law did not refer to abortion, so it was overturned, that interpretation, and now we have legal abortion since September 18th of 2023, performed in Madison, Milwaukee, Sheboygan, up to 22 weeks gestation. Now, I know there are other hospitals that do abortions, because when I was on the a chairman of the department, I got our board at my hospital to approve abortions for lethal anomalies in the life of the mother. And so rather than sending them somewhere else in a community where they weren't from with no support system, we did them at our hospital. And I was trained at Mount Sinai from 1983 to 87. Mount Sinai was a Jewish hospital, and the Jewish people believe that life begins when you start your first breath. And we were the referral hospital for the whole state of Wisconsin. So hospitals, Catholic hospitals, hospitals that didn't have a provider would send their sickest patients to us when we were residents. I got the best training I could ever hope for at Mount Sinai, now Aurora Sinai, and I am so grateful for that. So I was actually the consultant for a lot of the doctors at my community hospital when they had both a woman with a lethal anomaly or a life-threatening condition, but also a fetal demise, because you have to use the same procedure if the mother has a fetus that dies in utero. You have to evacuate the uterus, and you have to know how to do that. You have to be trained, and it's you know, it does require some skill. So we worry about the training of residents now, and we'll hear more about that in a minute. But one of the things that happens in pregnancy is intimate partner violence increases. So it's a risk being pregnant. And you can lose your life when you're pregnant. When I was on maternal mortality review, we saw homicides every 2 months when we reviewed cases. There were suicides because of severe distress and mental health conditions. And it also causes negative health behavior like alcohol and drug abuse, smoking, low birth weight, reproductive losses, complications of delivery, and of course physical and mental health complications, just the physical injury of some of the violence that we saw. And there were some really horrible cases. So just being pregnant puts your life at risk for so many reasons. And so if someone doesn't want to be pregnant, they should have that option. It doesn't matter what the reason is. It's not me to judge, just like they said on that video. I am not the judge, but I certainly would give them all the options so that they could make an informed decision. Each year, 324,000 pregnant women in the United States are battered by their intimate partners. And this is very serious for both the mother and the infant. This shows where the abortion policy stood in 2022. Wisconsin was restrictive, but you can see the red or the bright orange, Idaho, the southern states, South Dakota, it's worse there. And we know now that there are cases in Georgia that actually, because of Dobbs, women have died. Same thing with Idaho. So even before this reversal, there were trap laws. These are targeted restrictions on abortion providers, and they're designed to shut down abortion providers and centers through costly and medically unnecessary requirements. There's a whole list here of Wisconsin trap laws. They've tried all kinds of things. In 2013, they required abortion providers to have hospital admitting privileges. And some of my friends that were doing some terminations in Milwaukee had to work with some of the hospitals to try and get that resolved so we could still have care in our city. But public funding has been banned, private insurance limits it. You have to have an ultrasound. So when they were debating this bill, I got a call from the Legislative Council on a Saturday afternoon, and I thought, why is this person calling me? Well, the original bill had required a vaginal ultrasound. And she said, is there any reason that you'd have to have a vaginal ultrasound before an abortion? And I said, no, that's assault, basically. And you had to have an ultrasound even if you'd had already had one at a doctor's office. So this was totally unnecessary, extra cost, and not these are just ways to try and make it difficult. And the doctor had to read a script. So it's ridiculous. There's also a 24-hour waiting period. And so if you live in a rural area where you're not close to one of those 3 places, you may have to travel a long way. And the same physician that does the counseling has to give the pills if you're doing a medication abortion and watch the person take the pills. So now she might have to be there for 2 or 3 days and pay for the transportation, maybe pay for childcare. It's every single thing that they can make a barrier they've tried to do. And then came the 20-week post-fertilization ban. So this is unnecessarily confusing. We date pregnancy based on last menstrual period. So post-fertilization usually is 2 weeks later. So this is actually, you can have a termination up to 22 weeks of pregnancy based on obstetrical dating. But that caused confusion. So when my colleague in Madison, an OBGYN doctor, found out at her anatomy scan at 20 weeks that she had a trisomy that was lethal. And the risk managers at that hospital said, oh no, this hospital can't do that. And she had to go to Northwestern in Illinois. Insurance wouldn't cover it out of state. She had to start a GoFundMe. It can be up to $25,000 to have a termination in the 2nd trimester. And then you're out of your community where your family is, your support. So this hit home right away for one of my friends. And this is still the case if you're past 22 weeks. In 2013, they passed this ultrasound ban, or the ban that we talked about. And if you violate that, it's a forfeiture of anywhere from $1,000 to $10,000 in civil liabilities. So the only exception is for life of and health of the mother, rape, and incest as far as this ultrasound requirement. So most of you know, if you have anybody that's in your family that's had a pregnancy recently, that we typically look with ultrasound at 20 weeks. And if a woman doesn't want to do that, that's okay. But most women do, and they think they're going to do it because they want to find out if they're having a boy or a girl. But that's not why we do it. We do it to see that the baby's healthy and the fetus doesn't have any severe complications and anomalies. When you find out, it's very devastating. And you have to, sit down and give the parents all the information, let them digest it. You can't make a decision overnight. It takes time, and if they choose to carry the pregnancy, we support them. If they choose to have the delivery and have palliative care, we set that up. We have a comprehensive birth plan, and we have sometimes a team with the neonatologist, the perinatologist, the obstetrician, the nurses, the ethics committee at hospitals. This is a complicated process that we make sure that everybody's on board and that the mother has what she wants for this pregnancy. But I can tell you that almost all of my patients, if they knew that their life was in danger or that they had a lethal anomaly of the fetus, they didn't want to continue the pregnancy. And it's really hard to walk around knowing that your baby's going to die. You might die in utero, might die when it's born. People are asking you, oh, what are you having? Is it a boy or a girl? When do you do? It's just so emotionally just unbearable for those women. And they think about it for a day or two, and most of them decide that they want to have a termination. We tried at my hospital to make a list at one point of all the conditions to satisfy the board. You can't do that. Every case is so individual, and you don't know what you're going to do until you're there. And so we just have to leave it up to the providers and the people that deal with these kinds of things all the time to help give the right information to the patient and the family. I did have a woman who had a trisomy 15, and she wanted to carry her pregnancy. We got to 35 weeks. She got very sick. She had HELLP syndrome, severe hypertension, which is preeclampsia, only it can turn into eclampsia, with low platelets, liver function problems, and she was very sick. So we induced her at 35 weeks. And the baby was born with a heartbeat, very slow. And I stayed with her until the heartbeat stopped and checked it periodically. It was 2 hours until that happened. During that time, I had the staff call 7 different hospital chaplains till we could find someone who would come in the middle of the night and baptize the baby and be with that mother. We can talk big and say, yeah, you should just have these babies, but then who's there to support them? Not only in those situations, but when there's, financial situations, housing situations, all those other things. Luckily, we have checks and balances, and I testified against the 4 abortion bills that were up for just for vote in 2019, and they passed the legislature, but I was invited to the veto by Governor Evers so that we didn't have those go into effect. And I feel strongly that when we have the knowledge that I've been fortunate to get, that we have to go there and speak and stand up for this. But at one of those hearings, I heard from Wisconsin Right to Life that they want to get rid of contraception. They don't want insurance to have contraception. They don't even want natural family planning. And we have a Wisconsin legislator that said, we need a bigger workforce, so women have to have more babies. And you're hearing that in the discussion in this time period right now. We need more babies. So just have them babies. Just have some more babies. That's not how it works. So as co-chair of maternal mortality, this is a big job. And in 2020, 900 women in the United States died of pregnancy complications, a 14% increase from the year before and a 30% increase from 2018. The number of women who experienced pregnancy-related complications was also increased to 50,000. And we saw in Wisconsin that we had 49 deaths of pregnant women in 2020. In 2010, there were 25, and we are having less births than we were then. So less births, more deaths. And for every woman that dies, there's 70 to 100 women that have a serious complication, could be even life-changing, stroke, or I know one of my partners in practice had a patient that ended up with a liver transplant after a baby. One of the questions we ask, would she have died if she was not pregnant? And if it's pregnancy related, she wouldn't have died if she were not pregnant. The risk of death in pregnancy is 14 times greater with childbirth than with abortion. Homicides and suicides, as I mentioned, are increasing in pregnancy and the postpartum period, particularly 6 to 12 months postpartum. We're seeing way more deaths than we have before. Medical complications of pregnancies are going up. More women are having cardiomyopathy and congestive heart failure. You can get diabetes. One woman was offered termination. She had end-stage renal disease, and the pregnancy can worsen that. She opted to continue the pregnancy and then died. So there are so many situations that if they could get an abortion, it could save their life. I had a set of twins at one of the hospitals that was a religious, faith-based hospital. 21 weeks, the bag of waters broke on one of the twins, and that gestation is not viable. I offered to transfer her to the community hospital where we could take care of the pregnancy and keep her safe. The staff convinced her that no, that wasn't necessary, that she should stay there. And despite antibiotics, she got very seriously ill, had 105 fever. Fortunately, her body knew enough to start labor, and we got her delivered safely, but she was very sick and could potentially have had complications due to damage to her tubes and not been able to get pregnant again. So when you have premature rupture of membranes, that's one of the things they talk about. I know there's the story that has been told in the news about a pregnant woman in Texas who had to go out of state to get treatment for the same situation. A preventable death is one that has some chance of being averted if more than one of the system's family provider facility did something different. And so we're always looking at preventable deaths, and about 80 to 90% of the deaths we reviewed are preventable. A pregnancy-related death is one that's due to something specifically from pregnancy, a complication, infection, bleeding, things like that, or a chain of events that in pregnancy that lead to the complication. You can see in 2020, we went from 38 deaths to 49 deaths in Wisconsin, a 30% increase in pregnancy-associated deaths, and there were 21 deaths that were pregnancy-related, 43%. Of those pregnancy-related deaths, 38% were caused by mental health conditions, and 88% were due to overdose. So we've got a lot of work to do. And if you're not pregnant, a lot of that stress and that mental health problems can be treated much more effectively. We know racism plays a role in pregnancy-related deaths, and we are looking at every case. We've got some sophisticated ways now, and there's a lot of research in how to examine the record to find clues that there could have been racism that contributed to that death. As far as we know right now, I talked to the epidemiologist last week from DHS. We don't have any cases of maternal deaths specifically related to the Dobbs decision in Wisconsin. But there's been plenty in other states. Pregnancy Justice is a group that I've worked with for a number of years after I had a woman come asking for help because she was taking some of her mom's Percocet and she knew that was not good for her baby. And the ER doc called the police and they took her away to jail and then they put her in a locked psych unit in St. Luke's in Racine. And I called, it used to be National Advocates for Pregnant Women. They've recently changed their name to Pregnancy Justice because it's not just women that are having babies, but trans men who are cis women and are trans men can have babies. So they're being much more inclusive, and we are trying to do that with our research for maternal mortality review as well. There were 210 pregnancy-related prosecutions in the first year after Dobbs, with the highest number documented in a single year that Pregnancy Justice researched. And the prosecutions overwhelmingly charged pregnant women with offenses that allowed them to obtain convictions without having to prove that the pregnant person harmed the fetus or infant. 199 of 220 charges lacked a harm requirement. So in some states, especially in the South, if you have a miscarriage, they can charge you with, killing your baby. If you have a stillbirth, women are being put in prison because they had a stillbirth. They're saying that they caused it when they don't have to prove that there is that direct harm. And this is unconscionable. In Wisconsin, we have this cocaine mom law that you heard about, which is actually a personhood bill. It's under the child laws, and a woman can be reported to be using a substance or go in to get their Medicaid to get coverage, so they have insurance for their pregnancy, and say that they were using a substance, but they've stopped because they know they're not supposed to be using it. But if you have an aggressive intake person, they can report you, and then you can be forced to go into treatment, sometimes inpatient treatment far away, or they'll lock you up in jail. And I testified in the one case where we helped Tammy Lesher, who was put in jail and actually put in solitary confinement for a couple of days because she wouldn't give him another pregnancy test, which is ridiculous because the whole reason she was there. But there was another case, Alicia Beltran, who went before the judge, and it turns out that the fetus had a guardian ad litem, but she didn't get any representation. And she said, if I wasn't pregnant, this would all go away. And the judge said, yes, but you can't have an abortion. We won't let you do that. So you lose your rights when you're pregnant in Wisconsin. You don't get an attorney if you get charged with something like this. In 2021 in Texas, after the ban, the infant deaths actually went up in that state. And then there's the impact of the OBGYN workforce in Wisconsin. So even if you're practicing out of restrictive states, people face the fear of civil or criminal charges, fines, loss of medical licensure, among other possibilities. So if somebody in Texas goes to another state, someone in Texas can sue that person, the taxi driver or the doctor, whomever. In 2022, we had a 20% increase in death threats to doctors and 229% increase in stalking incidents compared to 2021. There are fewer maternal mortality providers now. There's more maternity care deserts. There's higher rates of maternal mortality and infant death, especially of women of color. There's a higher overall death rates for women of reproductive age, and there's greater racial inequities across the healthcare systems. Access to care is critical for mothers and babies. In Wisconsin, after 60 days, if you're above the 100% poverty level, you lose your Medicaid coverage. We've tried to get it extended to 12 months. Hasn't worked. I just saw in the newspaper today that we have turned down $1 billion+ because we haven't expanded Medicaid. It's going to other states. We need that money. We've paid our taxes to the federal government. It's our money. We should get it back. In the last decade, 11 rural hospitals have stopped delivering babies in Wisconsin, according to the Office of Rural Health. A maternity care desert is a county that has no hospitals that provide obstetrical care, no birth centers, no OBGYNs, and no certified midwives. Wisconsin has 15 counties that are maternity care deserts. They're losing, because of the closings, we have a stress on our whole healthcare market, and obstetricians are leaving our state. So when a couple years ago at Ascension St. Mary's, there were 12 OBGYNs. It went down to 4. I don't know what they have at the moment. All the OBGYNs just left the Menominee Falls, and they closed that birth center in Menominee Falls. I just heard somebody yesterday saying that there's another rural hospital that's closing its birth center. We have a physician shortage, and obstetricians are leaving our state and they're going to other states. And nobody wants to come here. So every week I get calls, text messages, emails, asking if I'll do a locums position at one of our Wisconsin hospitals because they're desperate for doctors and people don't want to come here. Same thing in Idaho. They've lost, 55 doctors or something. But that means that people aren't getting preventive care either. So if we want to go to the OBGYN, there might not be an opening for a long time. And so it's impacting everybody. We went to Washington, D.C. 10 or 15 years ago with ACOG and said there's going to be a physician shortage. The baby boomers are retiring. We're going to see a really big problem here. And they wouldn't approve of the increased funding to have more residency spots and more medical school spots. And now because of COVID, more people retired and the boomers retiring, and then these bans, it's made it even worse. Wisconsin OBGYN residency applications decreased by 8% in 2023 and another 10% in 2024. So we're not getting the doctors that likely will stay in our state if they train here. This is a really sad statistic. After the Dobbs decision, we saw a sharp increase in tubal ligations and vasectomies among young people, women in their 20s, because they were so afraid of getting pregnant and not being able to have an abortion. And the tubal ligations went up twice as fast as the vasectomies, but even the men were concerned. And that leads to regret, because I can't tell you how many professional women were busy and waited until their late 30s and then wanted to have a family, and because of age couldn't. But I think that we're going to see a lot of those young people change their mind 10, 15 years from then. We've had additional bans, and this is a hard one. I don't have anything against Catholics, but they run a third of the hospitals of Wisconsin, and many procedures are off limits. So there's a growing number of systems that limit reproductive health care, and in some instances, physicians are prohibited from informing patients about treatment options that are not permitted at the hospital, depriving patients of valuable information and the option of going elsewhere for treatment if alternatives exist in their community. Now, there's some communities in Wisconsin that there's only a Catholic hospital. There's lack of transparency, and I object to that, and I would love to write a bill that they have to be transparent about that. This shows all the Catholic hospitals in our state, and because of ethical and religious directives and this set of rules written by the U.S. Conference of Catholic Bishops, they ban abortions, contraception, and sterilization, as well as in vitro fertilization. So if you have a C-section in a Catholic hospital and you have 5 kids at home and you want to have your tubes tied, your abdomen is open, it'll take me 3 minutes to tie your tubes, you can't have it. Now, when I was at a Catholic hospital during my practice, we could go to the ethics committee, get a form signed, and if there was reasonable, reasons to do a tubal ligation, it was pretty automatic. But that changed in about 2019. Across the state, you cannot have a sterilization and you can't have a vasectomy. So now if you want sterilization, a woman would have to go to an outpatient clinic after 6 weeks, pay another copay, another anesthesia, which is a risk, another surgery, which is a risk. Maybe you've got a baby at home. Maybe you have to take time off of work. And one of the biggest reasons people go to abortion clinics is because they were denied a sterilization at the time of their delivery. This is not ethical to me. I really am sad about this quote. In reproductive care, Catholic ethics can trump medical best practice. Bishops can wield more influence than physicians, and patients can be denied care they desire or need. And the Catholic health systems argue that they serve as safety nets in impoverished communities and provide the same quality of care as secular hospitals, which that's not true from what I just said. They do. St. Joseph's in Milwaukee almost closed in 2018, and I was on several calls with doctors that were trying to help keep it open because they serve the people of that community, which is predominantly Black, low income, and they already have significant challenges. Nearly a third of the people there live in poverty, and Black infants born there are more than twice as likely to die as white infants. The 3 core values of reproductive justice are the right to have a child, the right to not have a child, and the right to parent a child or children in safe and healthy environments. And we're not doing a very good job. As far as racial disparities in Wisconsin, 45% of Hispanic women give birth in Catholic hospitals, and Wisconsin is the only state where Black women are more likely to give birth in Catholic hospitals than non-Catholic hospitals. And the number of Catholic hospitals are rising in Wisconsin, and the secular hospitals are decreasing. And on Black women, 52% of them in Wisconsin deliver their child in a Catholic hospital, the highest percentage in the nation, according to Columbia Law researchers. The bans won't stop unless we take action. In January of this year, the Assembly approved a bill by a vote of 53 to 46 that would call for a binding statewide referendum to ban abortion after 14 weeks of pregnancy. No Senate vote was taken because they knew that if they did pass it, it would get vetoed, so they didn't want to waste their time. But they're not going to stop. And we have to be on guard. So in 2019, I think this was when we had the 4 abortion bills that I testified against, I went to the rally at the Capitol, that we need to stop the bans. We need to do everything we can. And we also need to call our legislators to codify Roe versus Wade. That can happen. And we need to be calling our federal legislators. And why? Because women's lives matter. We can't let this happen. So, for the election, confirm you are registered, know your voting place, learn about the candidates, support candidates who uphold your values, and bring 3 more voters, and vote. Make sure you vote. And don't forget, the back side of your ballot has an amendment. I think the league has an opinion on that one. Vote no. All right. Thank you very much for your attention.
I'm falling over. That was a wonderful presentation. Did anyone have any questions on cards? Oh, we will. I can go down and get that. I'll be like I'm at a talk show. How fun is that? Okay. Is codifying Roe versus Wade adequate? Will we still have lots of restrictions in Wisconsin? That's an informed person. Here you go.
I don't really know. That's kind of a legislative question that I'm not qualified to answer. But yeah, I don't know, because we had it before.
We would then sue on the other bills. We would then probably sue.
Oh, then we could sue on the grounds of her. Yes. We'll worry about that after we get past the most important part.
Okay, well, thank you very much. Okay. Our next speaker will be DalveryBlackwell, who is the Executive Director and co-founder of the African American Breastfeeding Network. Frequently referred to as the AABN, she is a certified lactation consultant and holds a bachelor's in journalism and communications. The AABN was established 15 years ago with the goal to improve maternal child health and champion breastfeeding equity. The organization is committed to advancing system and policy changes, partnering with allies, and implementing community-based, family-centered, cultural-tailored health education and support services, such as their doula services that Dalvery will talk about tonight. Through Dalvery's leadership and vision, the AABN has built goodwill in the community, resulting in both the organization and Dalvery receiving awards and recognition for their effectiveness. The AABN is the recipient of the 2024 Healthy Living Award from the YMCA of the Metropolitan Milwaukee. Dalvery is the recipient of an honorary doctoral degree of humanities from the Medical College of Wisconsin, the Black Excellence Award, and the Wisconsin Public Health Association Award for Excellence in Health Promotion and Disease Prevention. Please join me in welcoming DalveryBlackwell.
Thank you so much, Charlie, for that warm introduction. I really appreciate it. I'm honored and blessed to be here. Thank you so much for your participation in attending. I also would like to thank League of Wisconsin Voters, Milwaukee, for inviting me. I just want to start off by sharing that my organization is a community-based organization. We work at the community level to protect Black and brown bodies, to improve birth outcomes, to help families and birthing people have satisfying and safe birth options. And if parents or families wish to breastfeed, then we also help them experience healthy breastfeeding experiences, positive breastfeeding experiences, so that they can give the best nutrition for their babies. My mouth often gets dry. Can I?
Oh, certainly.
Thank you so much. Okay, this is even better.
Do you want me to open?
Oh, no, I can do it.
Okay.
So I have two beautiful children. Sequoia is 21 years old. Aldous, and she lives in Milwaukee. Aldous, he is 19 and in Tallahassee, Florida, at a historically Black university, doing really well. He did escape the hurricane that was there and traveled away, so he's safe. And And so I do want to share that I lead my work as a reproductive health advocate through my own lived experiences. When I became pregnant, I truly wanted to have a non-intervention, all-natural birth, and I felt that the hospital was an option for me. So my husband and I, we studied, we worked hard, we interviewed several midwives, and decided to have a home birth. Well, that didn't work out. It didn't work out because our insurance, we were self-employed, and so our insurance carrier would not cover a great majority of our home birth. So, and also, I developed gestational diabetes. So my midwife, rightfully so, said, oh no, Dalvery, you can't birth at home. We don't have a backup physician in the state of Wisconsin or in Milwaukee, where I live. And so I ended up having a beautiful hospital birth at the now old St. Michael's, just right before it closed, with a doula. I had never heard of a doula. So my midwife said, you must birth with a doula if you're going into a hospital setting. So I had a doula, and she was amazing. I was there for like 30 hours, and she stayed, I think 30 hours, 20 hours maybe, and she stayed with me. I had a non-intervention birth, no fetal monitoring, and this was the birth that I wanted. My second birth with all this, I had at home. So I lead my work with my experiences of having a hospital non-intervention birth and also a home birth. Which button is it to? Just wanted to give you some extra little background about myself. Is it the?
It would be this one.
Okay.
There you go. The one to the.
After having my children, I always knew I was going to breastfeed. That was not an option. Never saw anyone in my family that breastfed. I believe my cousin did. I saw her once, but no one in my family breastfed. My mother had 6 children. I'm number 5. And now we are an exclusively breastfeeding family. Usually we self-wean our children up to 3 years. My nieces all breastfeed. So we now are a breastfeeding family that I'm very proud of. So I always knew that I was going to breastfeed. So when I became pregnant, I recognized the disparities in my community and that there were no posters, no campaigns, no pictures, no doctor's conversations, nothing in the office about the value and benefits of human milk. And instantly, without a doubt, we created the African American Breastfeeding Network, and we're 15 years strong, so I'm very proud of my organization. Our 3 primary, our mission statement of the African American Breastfeeding Network is, of course, advocating for system and policy change, partnering with allies both locally and nationally, and implementing community-based, family-centered, and culturally tailored health education and support services. Now, I know that we've heard some statistics about the crisis we're having in Black maternal health, and I would like to share some more because it's important sometimes to repeat things that are devastating, unnecessary, and 100% preventable. So I'm going to spend some time, before I do that, I'm going to go through some milestones, but I am going to spend some time talking about the public health crisis with Black maternal health. So again, our A being major milestones, like we started in 2008 in someone's home. We got our first grant, I believe it was in 2009. And we have continued with a very rich history. In 2023, we celebrated 15 years, which was last year. So the public health crisis that's disproportionately impacting Black and brown mothers, I just want to spend some time to revisit this data again because it's very important to be reminded that we have a dire situation. So we know that Black women have the highest maternal mortality rate among high-income countries. We also know, as Dr. Harke said, that they are 3 times more likely to die from pregnancy-related causes. Black women are 2 times more likely to deliver premature babies, and infant mortality. Prematurity is the #1 cause of infant mortality, which is at 14% in Milwaukee. And then Black women also die from heart disease, cardiac events, preeclampsia, and they often have hemorrhaging, which could lead to death as well. The public health crisis is persistent across any income levels, all income levels, education, geographics, location. It doesn't matter who you are. If you're Black, you're more likely to experience, unfortunately, maternal mortality. If we take a moment and just think of the many celebrities, there's 2 that comes to mind. Beyonce, she didn't die, but she didn't have, one of her births was very risky and she had complications. So did Serena Williams. I can't think of Black women at this time. Well, there's 2 that have died recently because of the abortion ban. Amber Thornton, also in Georgia. Also, I think her name is Miller, Candace Miller. Those 2 women have died because of the abortion ban. We know that the drivers of Black maternal health is structural, systemic, and obstetrician racism. Excuse me. What we find with the work that we do with the AABN, I'm gonna talk more about our programs, is that simply birthing people call us on a regular basis. We get at least 2 calls a month saying that they're terrified of birthing in a hospital, in a hospital by themselves. And we know that one of the solutions is to birth with a doula, and I'm gonna talk about the Rights Community Doula program that we have. Reproductive health for Black women is intersectional. It involves sexism, racism, discrimination, and other social determinants of health. So what are we doing to support birthing people? I want to start with our breast chest feeding support services. We train people, women who live in the community that they serve. That's very important to us, that we train and support and employ women who live in the community in which they serve, so that the trust between the breastfeeding counselor or the doula or the father advocate is instant. The connection is instant, and so that services can be provided. We have 5 community breastfeeding specialists. We do not call them breastfeeding peer counselors. Any WIC coordinators or employees, we do not call our team breastfeeding peer counselors. They are community breastfeeding specialists with over 14 years of experience. We provide prenatal education, postpartum support. We also, because of the pandemic, we now have hybrid classes. And what we found is that like the abortion ban or abortion rights, reproductive justice rights, Black women want to have options. So sometimes they choose to come into the class, sometimes they choose to come into virtual spaces. We do home visitations as well inside the homes immediately after birth within 8 days. That is our protocol and our procedures for breastfeeding support services. I want to pause a moment and share that for the first time in Milwaukee County history that I have experienced, we have partnered with Freighter Hospital to do a pilot project, which involves 20 patients who have already birthed at Freighter. And what we're trying to discover is if we partner as equal providers with lactation specialists and community-based breastfeeding specialists, can we truly impact and improve breastfeeding rates? Exclusivity and duration are the targets that we're looking at, because initiation really doesn't tell us much. The only thing that it really says with breastfeeding initiation is that the mother tried to breastfeed or she attempted to breastfeed in the hospital. And we know that Black and brown women upon discharge at the hospital, usually duration or breastfeeding discontinues for a number of reasons. Already we have we have about 68 of our program participants attended the class this year. What our data shows is that when our families attend class, we have a 90% initiation rate. I wanted to speak a little bit about, you can't talk about serving families, reproductive health, and improving overall Black health status without talking about father and partner engagement. We got it right from day one. When we started in 2008, we recognized that health is not just the patient and the provider, right? It's the entire family structure. It's the support system for that particular mother. So we have always had father and partner engagement. We center fathers' work and what we do. We recently completed research about how are we centering fathers and the work that we do as equal partners. We have had a Fathers to Fathers empowerment group for fathers, just talking about not only reproductive services and breastfeeding service, but other things as well. And we also recently trained fathers as dad doulas, not as in the sense of they didn't actually were not doulas, but they were trained to understand how to partner with doulas. I wanted to emphasize that. So I want to talk a little bit about our doula support services, the Rise Community Doula Program. We actually started in 2019, not to provide direct services, but to really fill out what's happening at the community level, who's doing the work, what services they need as community-based doulas, and we learned a lot. We got a grant from the Wisconsin Partnership Program, thank goodness. When the pandemic hit in March of 2020, our grant had just ended. And remember, we didn't have direct services. That was not our intentions. We were just doing an informal assessment of why doula work is of value and important and improves overall health. And we discovered a lot together. But when the pandemic hit, instantly we knew we needed to make sure that we provided services to people going into the hospital because of the COVID-19. And so we wrote a grant, We Rise Community Doula Program, and we've been working 24/7 ever since. In 2024, this year, we've already have had a successful 200 assisted families with 200 families with births. We probably would meet about close to 300 this year before we finish this year. Last year we received 554 referrals. And our referrals come mainly from hospitals, but also from any organization working to improve maternal child health and women's health in specific. Our doulas are trained. We use the Health Connect One community-based doula model, because our doulas are community-based, meaning that what's the difference between community-based doulas and like practicing doulas? Well, community-based doulas, ethnically, they resemble the community in which they serve. They live in the community in which they're served. They're also paid. They have some of the same socioeconomic backgrounds, and it truly make a difference. Our doulas are full spectrum doulas, meaning that they start at pregnancy and end through the postpartum period. We provide 12 weeks of postpartum work or support. As I mentioned before, we provide trainings and workshops to help doulas get up to their core competencies. We require them to have, for example, CPR. They also have to take a class in mental health, first aid, and there's other requirements as well. We've trained already 48 certified doulas, and I want to pause for a moment and just share, we don't believe in asking people to work without paying them. It's insulting and disrespectful, especially this kind of work. All of our doulas are paid. And the way that they're paid, they're paid through a tier system. So if you are an advanced doula with over 3 years of experience, for example, you're certified, you get a stipend of $2,000. And we've discovered through the last 2 years that our organization is one of the few organizations in the country that reimburse doulas at that rate. Most organizations are, and Medicaid, unfortunately, are reimbursing at a rate that's not sustainable. And it's typically, thank you so much, it's typically like $1,500 to serve a family that they're reimbursing, and on average, a doula can spend anywhere between 58 to 82 hours, and sometime above that, supporting families. I don't think as a community and as a country, we don't know exactly, like we don't understand all of the work that the doula does, but it's more than non-clinical. It's more than talking on the phone. We encourage our doulas for the postpartum work, for example, to help with dishes, to watch the other children if the mom needs to take a break or to take a bath. So yeah, they go beyond the scope of work often. And so lastly, sometimes, unfortunately, a pregnancy doesn't end with the baby, so we do have our Healing Waters program. We offer monthly support sessions, also one-on-one support with families and the individuals who have lost. The Wave of Light, I left some flyers on the table. The Wave of Light is an international day of remembrance across the world. At 7 p.m. in Milwaukee, we light a candle in reference to honor those babies who unfortunately did not make it. And I just wanted to mention Chantel Riley is listed on this slide. She's with Dignity with Departure. She's our community partner working with Healing Waters. So I want to also share our community-based doula outcomes. For example, this is data from last year. We have had a 23% decrease in NICU admissions. We also have had a 16% decrease in low birth rate and 75% vaginal birth delivery. So our work is amazing. We're very proud of it. It's 24-hour work. These are some of the doulas we work with. We sign contracts, annual contracts with them, so they're independent consultants, doulas. And the reason why is that we need them to have autonomy so that they're able to be innovative, to change the work, to also speak to the work as well. So these are some of our partners. Of course, the work cannot be done alone. We have many partners, both nationally and locally. It's just not possible to lead this work without the support of so many individuals, funders, volunteers, and partners. So thank you so much for giving me an opportunity to share. Thank you so much.
Just wondering, that is a wonderful program. Anyone have a question? You know, I didn't write mine down, but my husband is a neonatologist, and if you have a 23% reduction in premature babies, those women need an increase.
Yes, they do.
I mean, that is cost saving at its best.
Yes, we talk about that every month. We talk about the fact that we're paying our advanced doulas $2,000 in all honesty, and they need what we're looking at is between $4,000 to $5,000. That's what we want to advocate for that much. Thank you. So yeah, we do agree that $2,000 is too low for this outcome and the savings that we're for the industry, for the hospital systems and the insurance companies. We recognize that. But our state and our country, there's a lot of fear around the value and the impact of doulas, and there's a lot of misunderstandings as well. We do have the U54 research project that we're doing in collaboration with the Medical College of Wisconsin that I didn't mention. It's a 7-year project, and the primary goal of the project is to figure out how can doulas and healthcare providers work as equal teams, not as work as equal teams. And we do not want the hospitals to hire doulas either, because then the doulas are not working for someone and they can't change and speak on their...
Yeah, they wouldn't be helping with the dishes and doing all those things.
Yes, you're right. No, they would be primarily birth doulas in the hospital and not going, even barely doing prenatal support services.
I think most of us have had babies in this room, and it truly takes a village and people to help you during that period of time. So what a wonderful program. I have to say it's wonderful.
Thank you.
Okay. Our final speaker tonight is Representative RobynVining, who was initially elected in 2018, and she has spent the last 6 years in the legislature working on issues related to maternal health, infant health, mental health, reproductive health, and health care affordability and access. Representative Vining serves as the chair of the Milwaukee delegation. She is the ranking member on the Assembly Committee on Family Law and Mental Health and Substance Use Disorder. In addition, she serves as a member of the Assembly Committee on Health, Aging, and Long-Term Care, the Assembly Committee on Children and Families, and the Assembly Committee on Jobs, Economy, and Small Business Development. Representative Vining authored the Mental Health Care is Healthcare package of legislation and has co-sponsored and worked hard for passing of postpartum Medicaid expansion, and was honored to serve as the vice chair this legislation session on the Speaker's Task Force on Childhood Health. Please join me in welcoming Representative Vining. And I should have that. There you go.
Okay. Looking at the clock, and really grateful for all the wonderful things that we've heard tonight. And I'm going to shorten what I'm going to talk about a little bit. I know we're right at about 8 o'clock. So yes, I'm State Representative RobynVining. I represent the 14th Assembly District. That is the people of Wauwatosa and West Dallas. And I'm really honored to be here. I'm really grateful that you're talking about reproductive health, maternal health, postpartum health, mental health, pregnancy health. These are things that we need to talk more about. And I'm really grateful that this conversation is happening here tonight. So, I'm here to bring you great news from the Wisconsin State Legislature. I will begin by saying that I think it is a fair ask from the people of Wisconsin that your elected officials figure out where the problems are, how to solve them, do the hard work of building relationships on all sides of the aisle, come together, and agree on legislation. And we have done that. I want to begin by crediting my colleague, Republican Representative Donna Rosar. She and I agree on some things, we disagree on others, and we have locked arms in the fight to pass postpartum Medicaid expansion. And in the spirit of bipartisanship, I also want to credit her for the fact that the Wisconsin State Senate, that is more conservative than the Wisconsin State Assembly, the Wisconsin State Senate has done the work. They passed postpartum Medicaid expansion 32-1. Almost nothing passes the Wisconsin State Senate 32-1. So this is an extraordinary act, and we know that the governor is ready to sign this bill. So we know the state Senate has passed postpartum Medicaid expansion. The governor is ready to sign the bill, and I have more good news. In the Wisconsin State Assembly, we need only 50 votes to pass a bill. And we have 66 co-sponsors. So not just people who are willing to vote for it, but people who have signed their names on as co-sponsors to pass postpartum Medicaid expansion. So we have the votes, we have the governor ready to sign it, we have the bipartisanship, we've done the work, and we have leaders on all sides of the aisle ready to get this done. And so the question always is, well, why isn't it finished? And the reason it's not finished is because what's true is not necessarily that you have to have the votes, but the speaker has to have the will to allow for a vote. So the speaker has to call a vote or allow for the vote to be called. And he has a personal opinion that this bill should not be passed. So We are at a place right now where we really have done the work. We've built the consensus, and we know the need. We saw that in the last number was that 49 women had died from postpartum causes. We know that women are dying. We know that from data across the country, we are one of only 2 states nationwide that has not passed postpartum Medicaid expansion. 2. It's us and Arkansas. It was 10, and then it very quickly went down to 2. So the momentum's there, but we have data from the states that have passed it, and we know that, that the benefits are there. Medical outcomes are better in states where postpartum Medicaid has been passed. So we know that it's good for Wisconsin women. We know that Wisconsin women deserve this. And I would say that I know that this legislature has people in it who are ready to fight to get this done. So I think people ask, and I think it's a fair thing to make sure that I tell you, is, well, what does it cost? Is the hold up the cost? Well, the Wisconsin State Senate is known, really probably even nationwide, for not wanting to spend money. So the fact that it passed 32-1 in a state Senate that really doesn't like spending money, it shows you that they saw the value in the $8 million a year of general purpose revenue that it would cost the state of Wisconsin. $8 million. The rest is federal funds. And so that's the cost to taxpayers if you want to look at it from a monetary perspective. But I think I'll close with this. What does it cost to not do it? Women are critical to our workforce. Women are critical to our economy. Women are critical to our communities. Right now, women are dying, and the vast majority of those deaths are in the 60 days to the 12-month mark postpartum. So what happens if we don't do it? Well, women die, and they die unnecessarily. So the cost, when we talk about GPR, is $8 million a year. The cost is the fact that women are critical to our communities, our workforce, and our economy. That's the cost if we don't do it. So we need to pass this bill. Wisconsin women deserve postpartum Medicaid expansion. We know we've done the hard work to get it done. There's only one person standing in the way. And so I would encourage you to contact your legislators, applaud them on the bipartisan work, and let's get it done.
And any questions for Representative Vining? Oh, great. Do you? That's okay.
Sure. I like to remind him that he holds all the power here, and what an extraordinary move it would be for him to decide that we are going to save the lives of Wisconsin women. He's got the power. It would be an extraordinary act, and I hope that he does it. Yeah. We're at a nonpartisan event, so I won't say what I really want to say. But if the legislature make up changes, then maybe we'll see something shift.
There is one other question. If the assembly is not in session, will a vote need to wait until January 2025? So is that what we're now waiting until 2025?
It could be. So my understanding is it could be taken up in an extraordinary session where it could be. It's possible. It's possible. But what an extraordinary act for him to do after his 25 years in the legislature to finish his tenure by serving Wisconsin's women in this way. Yes. I can't remember if he has. We've had so many special sessions called that we've gavelled in and out of that I don't remember if it's happened. So many.
Yes, we
Yeah.
have one
Yes. So legislators never want to be wrong, and I haven't read the language of that particular lawsuit, so I don't want to guess. And it really depends on how things are written. I'd be happy to get you that answer. You're welcome to email my office, and we can get that answer to you. We can get it from a nonpartisan attorney at the state. What I can tell you is we do have a Restore Roe, I wanted to mention this, a Restore Roe bill at the state level. I'm a co-sponsor of that bill. That is a bill that is unfortunately still partisan. We don't have the bipartisan consensus on that, but we do have Restore Roe at the state level. Obviously, we want to see it done at the federal level to protect everybody across the country. But yes, and I think when you said that earlier, I think my thought process was actually tied to EMTALA, which is a different thing. But I'm happy to follow up. I just don't want to guess and be wrong.
Thank you. Yes, thanks for a great presentation and summary. Now, I want to clap everyone. You guys gave really great presentations that were wonderful. I know we are really sort of past time. We got started a little late. Are there any additional questions for the other speakers that people thought about? If not, I'm going to introduce Gail Gail, my co-chair for the Reproductive Rights Committee and the VP of Program. She's just gonna.
Thank you so much. This was great. You guys were great. Kathy, I had no clue about the Catholic hospitals. No clue. That's eye-opening for me. And, I forgot my phone. There's a book out by Jodi Picoult called Last Chances that talks about racism in a hospital delivering a death. Read it. It endeared me to her. And you're great. Oh my God, thank you for being nonpartisan at our nonpartisan event. If anyone wants to join our committee, I'm sorry, I'm putting in a plug. We really, really, really would love you guys to join. If you have an hour a week, great. If you have more time, even better. An hour a week, please think about it. So there is brochures on the table if you want to contact us. Okay, evaluations. Please fill them out. The most important question on this evaluation is, what do you want to hear from us next? What kind of session would entice you to spend time to come again? And Charlie, thank you so much. I know you worked really hard on this. I know it didn't go quite the way you wanted it to, but it was great. The last thing, please, if you haven't wrote your profound statement on why you're here and what reproductive rights mean to you and hung a ribbon, please do so. I'm going to post this all over social media, and the young people love it. Okay, thanks.
Thank you all for coming. Yes. Thank you very much. And this concludes our presentation.